Well, thanks so much for the invitation and for the kind introduction. So I'm going to be speaking about new weight reduction therapies, particularly GLP-1 receptor agonists. And so here are my disclosures. So I'll be focusing on obesity. So the objectives are to understand differences in obesity epidemiology between men and women with HIV, talk a little bit about current treatments for obesity, understand how GLP-1 RAs work and their impact on weight, glucose, and cardiovascular disease, and understand the data about the effects of GLP-1 RAs in people with HIV. And a lot of these data were presented at CROI last month. So we know that the prevalence of obesity is increasing around the world, and it's increasing more in women. And so here you can see that the light blue is the prevalence of obesity in 1975. Dark blue is in 2014. At both time points, the prevalence of obesity is higher in women than in men. And if you look in the U.S., for example, there are some groups of women who are disproportionately affected, including women of color, and you can see that on the slide, on the graph on the right. When you look at HIV, this is the people without HIV are from the NHANES data, and relatively similar prevalence of obesity in the men and the women, but a quite different story if you look at the people with HIV, with a higher prevalence of obesity in women with HIV, whereas a lower prevalence of obesity in men with HIV. And we know that there are some unique factors that are contributing to weight gain in people with HIV. So legacy effect of previous antiretrovirals. So we know that, for example, older protease inhibitors and thymidine analogs have specific effects on fat that don't actually go away even after a discontinuation. We know that antiretroviral initiation, just starting, increases body weight, and that's a recovery effect in people with low body weight, but this happens even in people with normal body weight, people who are overweight, and people who are obese. Weight goes up. And we know from the last, say, 6 or 7 years that there are specific antiretroviral therapies that are associated with weight gain, including integrase inhibitors and tenofovir alafenamide. The other thing that we know is that these effects, the effect of antiretroviral initiation on weight and the effect of these specific antiretroviral therapies on weight are greater in women than in men. And why that is something that's being hotly investigated, but it's true that we have to figure out exactly why that is. And there are consequences of weight gain. So diabetes it tends to go closely with weight gain, but also cardiovascular disease, hypertension, dyslipidemia, so all these metabolic problems. And then other things that may not be as clear, such as depression, cognitive decline, and frailty. So when we talk about treatment, the cornerstone of treatment really are lifestyle changes. And so on the diet side, you have the calories in. And we have this issue of portion distortion around the world, that we have when we go out to get fast food, for example, what we get is what we have on the left, and what we need is actually what we have on the right. So we're given much more food than we need, and we've paid for it, so we think we should eat it. And so we are getting all these excess calories. And the other side of things is on the physical activity side, and we know that sitting is a really detrimental activity, and in decreasing sitting and also increasing more vigorous physical activity is really important when we talk about maintaining healthy weight. The exercise obviously is important, and I show you this study. This was a study that was done by Christine Erlinson at the University of Colorado, where she took people with and without HIV and started a intensive exercise regimen. And I want you to look at the fat mass. So there was a significant decrease in fat mass over these 24 weeks with this vigorous activity. And these are people who are sedentary, middle-aged, and and you can see that the visceral adipose tissue decreased as well as BMI, and the effect was actually greater in the people with HIV versus the people without HIV. What was an issue with this study is that there were 7% women. And so this is a common theme as we see some of these studies, is that women are not represented proportionally, and clearly more data are needed to understand these effects in women. One potential strategy for weight gain, particularly related to antiretrovirals, is switching off of medications that are associated with weight gain. And so this is data from the ADVANCE study, where people were randomized to starting antiretroviral therapy, who were randomized to one of 3 arms, so TAF with dolutegravir, TDF with dolutegravir, and TDF with efavirenz. And so what this study that was presented at CROI last year did was they took a subset of these people and they switched them to the standard in South Africa where the study was done, which was TDF and dolutegravir. And what you see that I'm looking at the figure on the left, is that switching from TAF to TDF actually was associated with a decrease in weight. And so among the women, but not the men. And so it didn't come back down to baseline, but I think it was an important step. It decreased by about 30% or so. So clearly there's some data that are coming out, and we need to be thinking about potentially switching antiretrovirals to help weight. So when we think about weight loss, we can think about lifestyle changes, which get about an 8% weight loss, pharmacology, and then at the extreme, the most effective way to manage obesity is with bariatric surgery. Focusing on the drugs, things have changed quite a bit. We did this review back in 2017. These were the drugs that were available at the time. There are 5 of them. They all have sort of mild effects on weight loss, somewhere about 4% weight loss. One of them was taken off the market because of an increased risk of cancer. That's lorcaserin. The last one is liraglutide, and I'm going to be focusing on that class of drugs because this is the GLP-1 receptor agonists. And so let's talk a little bit about GLP-1 and what it is and what these agonist drugs are all about, because they have become very popular and are very effective. And so GLP-1 is a hormone that's released by the gut in response to a meal ingestion. And so normally GLP-1 is released when food is eaten. It has multiple effects, including increasing beta cell function, so insulin increases. It decreases glucagon, which opposes insulin. And it also has other effects in the brain, increasing satiety. So GLP-1 is broken down quite quickly by an enzyme called DPP-4. And so the strategy has been for the diabetes side of things is either to inhibit DPP-4, and there are drugs that do that end in gliptin, and then to have a drug that's like GLP-1, but that's not broken down as quickly. And so these are these GLP-1 receptor agonists. And it turns out that these GLP-1 receptors are not only in the pancreas, they're not only in the stomach where they slow gastric emptying, but they're in the brain where they increase satiety, and in the heart and in the kidney. And especially important for people with HIV, they're in the immune system where they regulate immune activation. And in the fat tissue as well. So there are multiple effects of these drugs, but beyond their effect on glucose. Oh, there we go. So these drugs were first developed for people with diabetes. And you can see that these are the drugs that are approved now in the US. And they do have a very significant effect on glucose, with semaglutide decreasing hemoglobin A1C by about 2 hemoglobin A1C points, which is really quite significant. Dulaglutide doing about the same. And they have very significant weight effects as well. But The reason why these drugs have been, in addition to their A1C effects and their weight effects, what's been really exciting in the diabetes and endocrine world is their effect on cardiovascular endpoints. And so we know, that decreasing hemoglobin A1C is a good thing, decreasing weight is probably a good thing, but decreasing cardiovascular disease, decreasing heart attack is really an important endpoint. And we know that with liraglutide, dulaglutide, and semaglutide, they all have significant effects in decreasing heart disease risk. And so as a result, these drugs are first-line treatment for diabetes for people with cardiovascular disease or at risk. And when we say at risk, this is most people who are 50 and older should be on these drugs to decrease cardiovascular risk. Another drug has come out more recently, and this is a agonist to two different receptors, two different gut hormones, GLP-1, like I told you about, and GIP. And this drug is called tirzepatide, and you can see a trial that was published in the New England Journal a few years ago where there are very significant effects of hemoglobin A1C, even more than semaglutide at a relatively low dose of 1 milligram, but about a 2.3 hemoglobin A1C point reduction, which is really quite a bit. And that has very significant effects on weight as well, that 15 milligram dose, with about a 12 kilo weight reduction, which is very significant. And because of this weight effect, these drugs have really sort of taken over as the way that people lose weight. And for those of you who prescribe these drugs, you know that it's been very difficult in the last year to get these drugs. And it's actually frustrating for everyone involved because there's just not availability. And there are sort of doc-in-the-box things where you don't even need to see your doctor in person. You can go online and get these drugs prescribed. And they are very effective, but there's questions about their long-term use. I'm not sure where the, there we go. So these are the drugs that are approved in the US for weight loss. So they're all, approved for diabetes as well. And you can see the weight effect particularly for the tirzepatide at the highest dose, rivals what you see for some of the bariatric surgeries. There are issues with them, which I'll talk about in a second. The other thing that's important, which people don't talk about a lot, is that there are about 12 to 15% of people who don't respond to them, even at the highest doses. And why that is, obesity is a very heterogeneous problem, and so there are different ways to get to obesity, so there are some people who don't respond to this mechanism. So let's talk a little bit about the good things and the bad things about these drugs. And so the issues, the adverse effects are the GI effects. And you start at a low dose and you go up slowly, stay at a dose for about a month. Nausea and diarrhea are the major problems, which tend to dissipate over time, but they can be treatment limiting. There are some concerns about pancreatitis and gastroparesis, and in the extreme form, bowel obstruction. There's questions about decreased muscle mass and sort of what that means over the long term. Facial lipoatrophy, and which has been called Ozempic face, so loss of fat in the face. There is some concern about suicidal ideation. I came across this study, which is a nice study looking at actual suicides in a very large database, showing no signal with these drugs. So I think that's probably not a causal type thing. You'll see in the package insert that there's a risk of medullary thyroid cancer, supposedly, but this actually was only seen in rats who are predisposed to medullary thyroid cancer. It hasn't been reported in humans, but that question comes up. The other thing, particularly for women of childbearing age, is the decreased effectiveness of oral contraceptives. For tirzepatide in particular, it slows gastric emptying, and it's thought to be that might be the mechanism. It decreases the area under the curve curve of the level of oral contraceptives. And the question is whether or not it decreases their overall effectiveness. Right now, the guidance is to have a different method of contraception during the first 4 weeks, because the symptom this issue with the gastric emptying tends to dissipate over time. So once you get up to the target dose, after 4 weeks, you can probably switch back to just the oral contraceptives alone. But all this data is based on one PK study, so I think it's important that more data come out. On the long-term benefit side, so diabetes prevention for people with obesity, I think is important. There was a study that was published in the New England Journal called the SELECT study, which took people without diabetes who had a history of cardiovascular disease and actually decreased the risk of major cardiovascular events by 20%. And so this is really significant. And actually just last week, Medicaid said that they were going to cover these drugs in people without diabetes, which is a really important step in the right direction. There's impacts on liver fat, adipose inflammation and systemic inflammation, ectopic fat, renal preservation. There's a study that was just reported. The top-line results were reported a few months ago. It's not in publication form, saying that these drugs do improve or decrease the risk of kidney disease. And interestingly, these drugs have show an improvement in physical function despite this decrease in muscle mass. And I just want to bring up this SELECT trial, which I was telling you about. So again, we don't have a lot of data in women. So the SELECT trial, even though it had 16,000 people in it, 17% of them were women. So what about GLP-1, RAs, and HIV? And so if you do a PubMed search, you see an exponential increase in articles related to GLP-1 in the general population. If you cross that term with HIV, this is what you get. So very few papers have been put out about these drugs and about this mechanism. Over in Denver, there were several studies about GLP-1s. This study was called Slim Liver by the ACTG group. This was a single-arm study of people with central adiposity and liver fat, and the primary outcome was looking at changes in liver fat over time. You can see the 52 enrolled, 49 completed the protocol, and you can see the dosing escalation protocol here with semaglutide 0.25 and up to 0.5, and semaglutide 1 finishing up. It should be noted that the current dose for diabetes is 1 milligram. The current dose for obesity is 2.4 milligrams. And so this was a relatively low dose. So here are the results. So there was a 31% decrease in liver fat. So very significant decrease in liver fat. And numerically, the women actually had more liver fat than the men, more liver fat decrease than the men. Of course, very small, so it's difficult to show statistical significance. When you look at body weight, again, a very significant decrease with about a 8 kilo or about a 17 or 18 pound decrease in weight over this relatively short period, again with this sort of mid-dose of semaglutide. Another study, another analysis of the slim liver was presented, and the question was about muscle fat and muscle volume. So I mentioned that muscle, in addition to weight loss, you get muscle loss as well. And so what you see here, this is the psoas muscle, and then fat within the psoas muscle. And what you see is that the psoas volume actually decreases with semaglutide. And there's no difference, and you can see that, down below, between the effect in men and in women. And so the question is that a bad thing? Is that associated with decreased physical function? And they did pretty extensive physical function testing. And what they showed is that, sorry about that, what they showed is that indeed there was not a decrease in physical function, and that in fact there was a trend, if anything, for physical function to improve. They had people rise up in the chair 5 times as fast as they could. and 10 times as fast as they could. They had did a 4-meter gait speed test, and you can see that physical function actually tend to improve. Interestingly, if you look at the graph on the right there with the 10 chair rises, there seemed to be a difference between the men and the women, which is something that was not expected at all. You can see that things seem to improve in the men, but actually worsened in the women. Another study was presented back in the fall, looking at semaglutide for patients with central fat accumulation. This was a single-site study, 32 weeks, and there were significant decreases in visceral adipose tissue, so fat within the abdomen, subcutaneous adipose tissue, and body weight. The study that was presented at CROI looked at this same study and looked at the effects on systemic inflammation, and there were significant decreases in markers of systemic inflammation like CRP, IL-6, and CD163, and these have all been associated with various outcomes, or elevated in people with HIV, and have been associated with bad outcomes in people with HIV. So having a drug that can bring these down, and interestingly, this was not associated with the decrease in fat that I showed you in the previous slide. So it probably is that direct effect on the immune cell. So the burden of obesity is higher in women compared to men, especially in people with HIV. Women are more impacted by these antiretroviral effects than men. The cornerstone of obesity management involves changes in diet and physical activity. The issue about switching off of medications, antiretrovirals that may increase weight needs to be further investigated. In order to get weight loss that's more than 10%, it's going to require pharmacologic and surgical interventions. And these drugs, GLP-1 RAs and these quinquertins, so these dual agonists, are important parts of the armamentarium. And I think that we'll be seeing more and more data regarding incretins, so GLP-1s in people with HIV. So I'll end there.